Welcome to the Thinking in Between podcast, where we explore the borderlands between health and social science. Each episode, we're joined by a guest who's working in this space to hear about 3 ideas that have most influenced their thinking and their approach to research. Today, I'm joined by Aida Hassan, who is a PhD student at the Centre for Public Health and Policy at QMUL. I'm really excited to hear from Aida today, as she comes to health research with a real different set of insights and backgrounds coming from international relations and political sociology. And today she's going to speak to us about the concept of totality in social theory, the influence of Edward Said, and the tensions between global health and national security. Aida, thank you so much for joining us today. And could you start by saying a bit about your background and how you came into global health?
Yeah, sure. So my kind of original background, or what I studied during my undergrad, was actually biology/natural sciences. I originally trained to become a forensic scientist, only to realize I didn't really enjoy science that much. But I've also been interested in questions around politics, understanding social issues, law, etc. And so that's kind of how I realized throughout my kind of forensic science journey that I was interested in understanding how, for instance, how does all these aspects either shape science or how does it shape public health generally? And I kind of took a very roundabout turn in understanding, how do we see or view humanitarian emergencies and issues around global health, particularly, for instance, as somebody who kind of grew up in a Western country, why is it certain access to medical-related technologies exists here but doesn't exist elsewhere?
Yes.
And why is there this kind of underdevelopment of health and health systems in comparison to the UK context, which is probably not the best approach to take into it in retrospect, but I think for me it was my kind of starting point into global health.
Yes.
And so I think from there, and I was also really interested to kind of understand it more from a knowledge perspective, more epistemologically, and also researching these ideas in terms of, I felt there was a bit of a gap between kind of the questions around politics, international, the state of international affairs, and also with public health. So global health seemed like the perfect fit for me. And I basically embarked on this PhD journey, starting off with a master's of research through my 1+3 studentship, basically doing academic research without actually knowing much about global health.
Okay.
Again, it was just this kind of idea of understanding and reading a lot about global health, or reading a lot around public health issues, and just understanding that massive divide between why is it certain conditions why is it health inequalities are bigger in, for instance, African, Asian, and other contexts in comparison to the UK, which was, I think, for me, the starting point, and kind of questioning why do these humanitarian emergencies exist? Because I don't think it was just about the fact that there was just around the access of technologies or, again, underdevelopment of health systems. I felt like there was a massive political dimension at play rather than just the biomedical paradigms of health. So I kind of wanted to deepen my understanding of that. And I actually did my Master of Research on Global Health/Social Sciences here at Queen Mary.
Okay.
And so I think we took a very social science approach to global health. And I think from there, I knew that I just wanted to abandon the biomedical paradigm of public health and global health generally, and just go more for the either sociology or kind of political science aspect of global health instead.
Yeah, wow. And so what is it that you're doing your PhD on now?
So I'm doing my PhD on global health governance, and I started off originally trying to understand humanitarian health emergencies in conflict-affected areas like Somalia, Syria, Yemen, etc. Although now I just focus on Syria and Yemen and taking a comparative approach. But understanding the kind of actors who are at play in trying to govern health emergencies in these contexts. So specifically, I focus on states and the state system generally, and how not kind of exploring whether states are good or bad for global health, but kind of, again, trying to take a more political approach and understanding that they're not just neutral decision-making bodies who actually can have an impact or a negative impact on people. So some of the theories that I use in my PhD research are mainly post-colonial theory, and also necropolitics as well.
Okay, thank you. So the first idea that you are bringing today to the podcast is this idea of totality. Could you start by saying a bit about what totality means, and then maybe a bit about how it shaped your thinking?
Yeah, sure. So totality is interesting because I've been dealing with this concept of totality without actually realizing it was totality, or there's a name for this problem. So totality essentially refers to this idea of like whole thinking, particularly in structural context of, or historical context of like a whole approach to society to some extent. So say if I was interested in political economy, my totalizing approach would be just looking at capitalism in the kind of wider structure of everything. So that would be world economy, that would be the neoliberalism or other relevant sort of economic structures of the world, etc., or even the modern state system at the large kind of level or the macro level. But it could also apply to other aspects, like how do we see these structural forces of racism as one massive structural force, or like how do we see coloniality as this one massive force? So it's kind of, again, just taking this very massive, like, whole system view of a particular phenomenon in society that affects us. But that isn't to say totality is necessarily like a bad thing or anything. It's just, I think it's very common in like critical social theory paradigms where, for instance, Marxists will look at capitalism as just one huge kind of force, and class systems as one. Even though a lot of there's been like popular critiques of Marxist theories for kind of taking an ethnocentric approach to class and capitalism, just because class could be conceived very differently in various contexts all over the world. And this system of class that mainly comes from understanding class either within the Western context, that could be the UK, Germany, etc., doesn't necessarily apply to other areas or other regions of the world. Right. And so I think that was one of the challenges of totality in relation to Marxism. But it's also just looking at, like one particular thing that I look at in my PhD research is, again, taking more of a post-colonial approach to global health issues. So I do kind of interrogate coloniality to some extent, or to a large extent, but it's a bit of a struggle just because coloniality is massive, but it's also very pervasive throughout every structures and units of society. And so it's hard to kind of capture these nuances of coloniality if I am taking a totalizing approach, which I think to some extent I was at the beginning, because when I started off my PhD or started off my kind of academic journey into global health, I didn't really know much about global health itself. And I knew systems of coloniality and racism existed within global health, but I just didn't know what the nuances were and how that was relevant to global health policy, to understanding the prevalent actors in global health. And how does that even kind of like not trickle down, but how does it kind of like, how does a system of coloniality also then really affect the everyday nuances and everyday mechanisms of just health generally for people who are affected by some of these major issues?
Yes.
Yeah.
Is it, like, just to check if I'm understanding it, so is totality, is the sort of potential problem with it that you stay at such a high macro level that it's then very difficult to reconnect that to the actual levers and mechanisms that affect things on the ground. So you just stay at this kind of very conceptual level, assume it applies everywhere, but actually don't fill in the detail and see, maybe it doesn't apply quite like that to this particular situation.
Yeah, exactly. So I think it's that problem of the kind of macro to the micro level sort of, the kind of micro level consequences of it, essentially. But it's also, how does these big concepts travel throughout space or travel throughout, again, various geographies and regions of the world? Because say, for instance, like racism in health, I think there could be very different experiences of that. And I can only speak to this from my British perspective of also being a Black Muslim in the UK and who's been as kind of through the NHS system. I also know that my experience might not resonate with other Black Muslims in other parts of the world. So my home country, or country of origin, Somalia, for example, or other parts like of East or West Africa. But also even like members of the diaspora in like the US, for example, where the US has more of a privatized system. So I think it's, again, like, it's how does that like massive thing that exists at the macro level sort of just the nuances in between.
Yes.
Yeah, even like from just between space, but even just thinking about temporally as well, like how does that like experience just kind of change throughout time? Is there a historical context we might be missing?
That's fascinating. So like, as in, if you apply something that we just take for granted is like this a thing of racism in healthcare, and you say, but racism in healthcare is still a thing 50 years ago or 50 years in the future or in this part of the world, but it's not necessarily the same thing, and but it's easier to talk about it in that sort of flattening way as if it all was the same thing.
Exactly. Exactly. And I think an interesting example that I could probably offer is before I started my global health masters and PhD, so this was during COVID, and obviously what happened during June 2020 with the murder of George Floyd in the US, and it obviously created this like global movement of anti-racism, and I think everybody recognizing that racism, surprisingly, a lot of people recognize racism for the first time, like it exists in society. I was like, yeah, it's kind of been, it's been existing for a while. I use that very sarcastically. But I think it's just, one of the things I've noticed was people say, especially within the academic and policy debates, was racism is a public health emergency, which I thought was really interesting because, again, it took this very totalizing approach to racism, and it took a very flattening approach as well, where it just kind of amalgamated all these various like different groups of like different racial groups, etc., as one. Like terms I saw was like the BIPOC or BME, for example, just these massive like umbrella terms for race, or like other terms like racially minoritized, or again, similar terms like that. But again, it doesn't really capture the nuances between various groups of people depending on how they're racialized, and even the structure of racialization itself. So migrants, for instance, who are also racialized, but they're kind of left out from those conversations around racism in healthcare. And I think it's just, again, I'm not trying to say that totality is reductive or it's flattening completely. It's just, it really depends how we see it, because there is obviously an important way how we conceive these massive structural forces of inequality and oppression and dispossession, for example. So it isn't to say that we shouldn't be thinking about racism as this kind of whole totalizing approach, because we're kind of in an inundated in society that is determined by racial hierarchy and colonial hierarchy. So I think it's obviously important to see that, but I think it's, again, trying to capture the nuances, but it isn't necessarily just, trying to meet the macro with the micro, but understanding historically, maybe even kind of spatially as well, how do these various kind of structures and like systems kind of differ across people, across regions, etc. And that's kind of what I do. Even global health is a very totalizing object, because how we see the global, again, like one of the massive debates going on in global health at the moment is like global health is not really global because it doesn't necessarily, it's more catered towards the interests of like Western societies and how they see medicine, how they see health, how they see technology in comparison to other like non-Western societies essentially. But I think it's interesting because I think that's the problem with global health, is that in itself is very totalizing, that it's very hard to conceive of the global because we have very different kind of values, we have very different agendas and interests at mind. Some of them even contradict with each other. So it becomes hard to kind of marry that as one.
Wow. Thank you. That's really, really helpful. And could you tell us a bit about how the concept of totality has influenced your research?
Again, how do we conceive like the modern state system, which is something I look at. So the role of states in global health emergencies, for instance. And again, there's a very universal idea of what the state is. Most of the time it's neutral, most of the time they take the state for granted, especially among global health academics, either in international relations or other aspects of social sciences, which I think becomes a bit of a problem because states and even the political structures and economic structures of a particular country or society generally, it could be very different across the world. So because I look at health emergencies in areas affected by conflict and the humanitarian emergencies that kind of concur from these conflicts, or occur, from these conflicts, it's most of the time they're just kind of seen as like the bad state or the fragile state or the failed state because they don't necessarily meet the standards of a state or universal kind of idea of a state, because they're undermining health directly and also undermining health deliberately. But I think it's a problem because states can act very differently, but there is that kind of, and most of the time it's there to legitimize that kind of colonial context that it's global south states that are bad and global north states that are bad because global south states don't meet the requirements of the universal ideas of what a global north state should be, even though they're the ones that created this system, which is arbitrary and doesn't necessarily meet the kind of heterogeneous ways of conceiving politics and how economic structures are governed, essentially.
Yes.
So I think that's how totality also came about in my research, because again, we take a very flattening idea of the state, and that's something that I'm trying to kind of interrogate a little bit more and deal with.
Thank you. That's really helpful. One example that I think might be related to totality that's stuck with me, but tell me if this is an example or not, is Paul Farmer wrote something about, I think it was, I can't remember if the context was HIV or TB. It was in a Haitian context. And he was saying, Paul Farmer, for those who haven't read his work, was a sort of global health leader, really, as well as a physician anthropologist. And he was talking about how, I think, let's go with the MDR-TB example. You could look at it at too proximal a level of cause, where you say the reason there's lots of MDR-TB is because of just something about the microbiology of it, and really just a descriptive thing of saying it is just there and it spreads in this way and this way, but without any bringing of humans or power or systems. But he said, actually, if you then say, oh no, the cause is poverty, he said, well, that's not helpful either, because like that's too high a level to do anything about. And so he said the right level, he felt, was to recognise, for example, the discourse around TB global health professionals had just solidified around this idea that it's too expensive or it's not possible to treat MDR-TB in a Haitian context, for example. And he was like, that's where the power, that's the sort of level at which you're not just saying, oh, it's just poverty, which makes it really hard to do anything about. Neither are you saying it's just how MDR-TB works at a microbiological level, but you're saying, if we could change the conversation that's happening in these rooms of experts, then that's where there's a proximal enough lever of power to do something about it. Now, I don't know if that's totality or not, but it just reminded me that, like, the idea of just deploying poverty and then moving on and not interrogating, well, what's underneath there? I don't know. Does that have anything to do with it, or do you think that's described as something a bit different?
I think maybe it does, actually, because and I think it kind of goes back to other realms of, like global health issues, for example. And most of the time, the kind of big conclusion that most kind of either researchers or practitioners or global health researchers come up to is, yes, poverty is a problem, and then that's it. Like, oh, we live in a society that's basically governed by poverty, by capitalism, and that's it. That's the main takeaway. But the problem is, we can't just assume that's the natural consequence, that because this is a huge thing and it can't be changed, that's it.
Right.
I think the problem is that these systems that create poverty can be changed to some extent if we kind of know what those intricate structures actually are. And again, I'm not a political economy expert, but I think if we just assume, yeah, capitalism, poverty, that's it, I think we then start to lose what are the actual structures, who are the people that are creating these decisions, that create these kind of outcomes of poverty that then makes it hard to kind of govern health or come up with actual solutions to health interventions, etc. So I think totality it can explain that particular problem that, okay, because we live in a society that's, again, governed by capitalism or governed by coloniality, etc., that these systems are so huge that we can't change them. It's impossible to create change. But the problem is these systems are maintained by something. We just need to know what they are. And we need to really interrogate who are the people who are involved in that, maintaining that system. What is it? What exactly is maintaining those systems? And be very critical of that rather than just assuming that we can't change anything.
Yes.
I think at the same time, people also come up with, not recommendations, but they come up with a conclusion that for us to overcome these major issues, we need to kind of get rid of poverty altogether. And it's like, okay, I think we need to be a bit more basically coming in with feasible explanations, because that also kind of comes in with how I teach students social terms of health and how I teach them social inequalities and the process of social inequalities. Their take-all kind of conclusion to some of these major issues is that capitalism is a problem, poverty is a problem, racism is a problem, coloniality is a problem, so we just need to stop doing these things. And it's kind of like, well, these structures are very linked to power.
Right.
And I think the problem is we don't have that. I can't say we don't have that idea of power, because we do. We are starting to kind of understand that more as global health researchers. But I think it's understanding how power is operationalized that we can just start to. I think if we did a bit more of that, we can then dispel and kind of start to interrogate those structures that maintain that power, if that makes sense.
Thank you. So the second idea that you're bringing to the podcast today is the work of Edward Said, including his most famous book, Orientalism. Could you tell us a bit about what you've learned from Said's work and how he's influenced you?
Yeah, sure. So when I started my kind of global health journey, I didn't know the first thing about post-colonial theory. And even now, being slightly a bit more well-versed in post-colonial theory because I use it for my PhD, the first book I basically picked up was Edward Said's Orientalism. And I kind of resonate with Edward Said because he was very vocal about this kind of binary thinking, or at least critically interrogating that binary thinking of West and non-West, modern, not unmodern, or sort of civilized and uncivilized, etc. And explaining the kind of justification or meaning for that kind of binary thinking. And so Edward Said's Orientalism, for example, he interrogated that analytical binary of what he termed as the Occident but the Occident and the Orient, so the West and the East, for example. So the driving force of European modernity, Edward Said argued, was it relied on that divide between this kind of idea that the West was the hub of modernity and naturalizing that thinking, while portraying non-Western / Eastern society, as he writes, as the opposite of civilization. But he kind of pushes it a bit further to say that this thinking became kind of legitimate in the sense that it seeks to justify and naturalize, or seek to justify the West's material domination of non-Western societies. So Edward Said writes a lot about the kind of ethnocentric demonization of Islam and Arab societies as this monolithical threat to Western hegemony under the guise of things like democracy, for example, which was interesting because this book I think was released in 1978, and this was at least a good couple decades before 9/11 and the War on Terror happened, where it was Islamophobia became very much entrenched in globally, actually, not just Western society, but it became very much entrenched. So for me, I think it helped with respect to global health. I think it was very helpful in understanding again, this binary thinking of the West is like very forward thinking or very close to the developed idea of this perfect system of global health, of public health generally, perfect health systems. Can't say perfect because the NHS is definitely not a good example of that. But it kind of explains the West as I guess the best way to explain it is how Western countries like the US, the UK, etc., sit at the gold standard of health in comparison to non-Western countries, and particularly demonizing or kind of othering African societies as the threat to that gold standard of health because this is where all the diseases lie, etc. And that was one of the legitimate ways of thinking that also goes back to the justification for things like imperial medicine and tropical medicine, etc., or imperial hygiene, and why global health started was to protect the kind of colonial imperial armies that were going about their colonizing kind of objectives and or their imperial objectives, but were afraid of contracting diseases that most of the time they brought themselves from Europe. So I think it was, again, it started off as this kind of innovation of medicine and innovation of public health to protect the imperial interests of these former kind of colonial powers in comparison, and kind of now legitimizing that to say, like, a really interesting example I can give is the travel bans, for example, that happened with the Omicron variant back in 2021.
Right.
And so how South Africa was apparently the hub or the kind of, it was apparently the hub for like the Omicron variant when it actually wasn't true. I think it originated from the Netherlands, I'm not too sure. But a lot of like the UK and the US and other various European countries kind of jumped to the conclusion that, we need to kind of stop African travelers coming in to basically across our borders and push out these kind of travel bans, which were incredibly racist, and it kind of, again, objectified and also dehumanized like the African community, essentially, in trying to, again, portray the idea that we as Black individuals are the problem, and it's white bodies that need to be protected.
Right.
Yes. So I think that was something that kind of helped me with, something that Edward Said's kind of orientation helped me with is just understanding this kind of racist divide in terms of who is protecting global health, or who is the subject of global health, who's the subject of global health and who needs protection or who is a problem, etc. Does that make sense?
That does. Yeah, thank you. And I guess particularly, I'm really glad you made the example of something that's just happened a few years ago, because at face value, it just looks like objective public health measures or something. And then you realise that it's sort of drawing on these myths and ideas that have been around for much longer, and that it makes me think a little bit about some of the origin stories, or the way the origin stories about HIV are portrayed as well, with sort of notions of bushmeat and just the whole way it's talked about. I don't know. It's sort of, I don't know. It feels similar somehow. It feels like there's something that's not just objective speech, but a drawing on notions of where the safe, healthy countries are, and where the dangerous place that disease appears.
Exactly. Yeah. And most of the time, it's just, again, like this binary thinking is just, it naturalizes or kind of legitimizes this idea that it's African and Asian countries that are a problem, that are the threat to global health. And a lot of the times they use this objective, they use a language, like scientific language around objectivity and evidence-based approach. When again, the example of like the travel ban wasn't objective. It didn't come from a scientific basis at all. It's just, again, how do we protect our borders? How do we protect our economic and kind of political interests? And how do we maintain that order that COVID has been presenting as a threat to? And it legitimized racism without, again, like being very obvious that it was a very racist move, even though the public acknowledged and recognized that it was a very racist move.
Yes.
And I think the example of HIV is also, it speaks to that, because this is not something that just happened with COVID. It's happened in previous, even historical kind of cases as well. But most notably, it also, I think the 2014 Ebola response definitely speaks to that. And again, a lot of the narratives around Ebola and Ebola response was highly racialized and just generally just outright racist. But I think, again, that binary thinking of we need to protect the civilized West in comparison to the non-civilized other legitimized that kind of rhetoric around Ebola.
And for your PhD research, are there particular ways that Edward Said's work and thinking has helped you to see your work about states?
Yeah, so with Edward Said's Orientalism, I definitely think it helps in terms of thinking about the powerful states in global health governance that actually have a say, that have influenced most of the norms around responsibility of the state, etc., in comparison to mainly pathologizing not like global South states as a problem, and how it pathologizes states that are engaged in conflict as a kind of deviant other from human rights objectives, etc. But I think for me, as much as I do resonate with Edward Said's work around Orientalism, there are certain pitfalls with it. I think his work definitely speaks to the more textual and kind of cultural politics, but I think it doesn't. It definitely has applicability to understanding the major political forces and whose kind of material domination and material powers are legitimized in global health governance and even other aspects of global governance generally. But I think from a more, I suppose, more political aspect and understanding the kind of forces involved, I think it doesn't add that, it doesn't really push it further.
Okay.
And I think that's a lot of the critique that Edward Said faces a lot, or his work around Orientalism faces a lot, which is why, but I think it was definitely a very useful entry point into exploring other post-colonial sort of thought. So for example, one particular theory that I use a lot in my PhD is Akilimembe's necropolitics, which I think kind of complements some of the, it complements a lot of Foucault's biopolitics, but I think even though Akilimembe doesn't bring it up directly, there are some origins to some of these original thought in post-colonialism, such as Edward Said.
So the third idea you're bringing to the podcast today is a really interesting tension that I have not thought about before, I don't think, but I'm looking forward to hearing about, of the tensions between global health and national security, even international security. So could you tell us a bit about some of these tensions and about how they've influenced your approach to research?
Yeah, sure. So I think I actually didn't really know much about this kind of linkages between security and global health, but I think for me it explains what global health actually could be about. So I think it was during my first year of the PhD, I read this really groundbreaking paper by Professor Simon Rushton from the University of Sheffield, who wrote this really interesting paper on global health security, security for whom and security from what. And the main interesting thing about it was, this is something that he published back in 2011, just also like a few years before Ebola response happened in West Africa. Essentially, this area of global health governance, or agenda global health governance, referred to as health security or global health security. And it's something that sits within mainly the foreign policy areas of the UK. So the UK has their own foreign policy on global health security. So does the US, and also the larger kind of group of 7. So that's like the US, the UK, France, I think also Germany, and Japan. So all these various countries that are involved in the group of 7, which I can't remember off the top of my head.
Yes.
But these are also they're mainly like rich industrialized countries that are involved in global health security. And they don't say global health security specifically. They kind of, or they, to some extent they do, but they're also, it's under the guise of like global health, advancing global health across the world. But most of the time, their global health security policies are targeted at how do we protect the national security and economic interests of from global health threats, so from infectious diseases, etc. So the main premise around it is following from the aftermath of the HIV and also from like other pandemics that could be on the rise. How do we protect our order from the threats that the threats posed from public health kind of infectious diseases and other public health threats or cross-border threats. And a lot of it's also targeted around migration and how migration also kind of increases this idea of increased cross-border movement of diseases, which kind of stems again from that racist logic, which I mentioned earlier. So yeah, global health security, again, the object of security there, or the object of global health security are Western states. But in comparison to the rest of global health, which is meant to be global health for all, or health for all, which is, it goes back to the WHO's 1978 also Declaration on Advancing Primary Healthcare for Everyone. There's these kind of areas of global health that clearly it kind of contradicts each other. So for me, that ideal, the linkage around global health and international security explains to me what global health could actually be about, or what the main rhetoric or the kind of main areas of global health at the moment could be about. So in my PhD research, security is kind of a twofold issue, because I look at security in conflict-affected areas as well as public health emergencies. And so security in this instance could be security from non-state armed groups, or insecurity threats from non-state armed groups, but also insecurity from public health threats like infectious diseases, so COVID, for example. And having to look at those kind of nuances in terms of whose kind of object is being secured, who is a unit of protection. Is it the people that are faced by these conflicts, by these insecurities, which are clearly evident, for example, people who are in Syria, in Gaza, etc., or is it just protecting the security and survival of the state, for example?
Could I ask, just to kind of make it really concrete, like, is there an example you could give of where there's two kind of policy options? One would prioritize security, one would prioritize health on the ground. Would you be able to give us an example of a fork in the road like that?
Yeah, definitely. So one particular example is, actually there's quite a few examples, but I'll give the broad example of allowing humanitarian aid or allowing healthcare interventions in areas outside of state control in conflict settings. So this would be areas under the control of non-state armed groups in Syria, for example, or in Yemen, where humanitarian access is barred or humanitarian access is limited because there is a risk that humanitarian aid or healthcare interventions could fall in the hands of quote unquote sort of terrorist organizations.
Okay. Yes.
But that becomes a problem when generally just in terms of access to healthcare, but also it becomes a problem during a health emergency such as COVID. How do doctors on the ground then access PPE, for example? How do doctors on the ground access these very vital resources to respond to the healthcare needs of the population affected, and also protect themselves as well from the threats of a pandemic?
Yes.
Or any other infectious diseases. So that becomes a problem. But also there is that kind of politics around, or the kind of intricate politics around humanitarian access and negotiations with the state, but also with non-state armed groups that could be pushing these very bureaucratic restrictions, again, where they kind of utilize health as for their own military strategic advancement. So an interesting kind of paper that came out in 2017 was by Professor Fuad, who wrote about the weaponization of healthcare in Syria. This was like a Lancet American University of Beirut commission on the issue of healthcare in Syria during the 2011 crisis and protracted conflict that's going on at the moment as well. So there was that clear targeting of healthcare infrastructures. There was that clear targeting of healthcare workers themselves, because all of it was kind of under the guise of protecting the national security and territorial integrity of the Syrian state in Damascus, which is under the Assad regime, for example. So again, a lot of that intricacies around security or national security with global health or the kind of prioritization of security was a problem. But going back to global health security as a policy agenda, it almost kind of feels like security and global health are like two sides of the same coin. Right. We need security for global health, but there are also instances where security doesn't help global health. And so the question is does security actually help any actor, whether that's states, whether that's policymakers, etc., even international institutions, try to advance most of their global health objectives. And a lot of my research around Syria and Yemen, but also what's happening now in Gaza, Palestine, says the complete opposite. I think the guise of security, or at least security, is just kind of used as an example, as a caveat to kind of the more state interests of protecting their political territorial integrity.
Thank you. So if we think about some of the discussion earlier about COVID and the international response there, I imagine that there were decisions there that could either have been taken to prioritise the greatest amount of good for the greatest amount of people globally in the COVID pandemic, or those that would prioritise the security of individual states and their interests. And that sometimes, I'm guessing that there were options that were taken more leaning towards the latter. Do you think that's an example of this sort of tension that you're talking about here?
Yeah, definitely. So again, I think that the travel ban aspect, or the response to those kind of COVID-19 variants, speaks to that, because you can legitimize those travel bans to say, we're here to protect and we're trying to limit the spread of disease even further, and we're trying to reduce the impact of COVID-19 by protecting people's livelihoods, their jobs, and the overall public infrastructures of their own countries, and how that would then have a ripple effect in terms of reducing the mortality of COVID-19 everywhere. But I think that is a justification that states could make. But it's legitimizing that racist response, or that racializing response, that African countries are the problem, so we need to limit the movement of people across borders and protect our borders, which again is very infused with racist logic that I don't think is acceptable, essentially. And I think the work from Edward Said and his theories on Orientalism speaks to that, because he does discuss how this binary thinking of modern versus uncivilized, or the civility or modernity of the West, is naturalized, is legitimized, almost normalized, that nobody would seek to question that this is actually racism in terms of their policy practices, in terms of also their cultural practices and how they view cultures as well. I think even like the cultures around COVID-19 and lockdown, for example, was entirely racializing, but it was again, it was just kind of legitimizes, we're in a state of emergency, so we have to take these exceptional measures, which I think also kind of speaks to Giorgio Agamben's kind of theory around the state of exception, which is, again, very biopolitical, but yeah.
So kind of bringing all this together, the sort of three ideas we've spoken about, how could you bring these together into some sort of question that your PhD is fundamentally asking?
That's a very good question. I think about this as well, like in terms of like what's the overall theme of, like what's the overriding theme of either my research or where I kind of sit within global health generally. And I think it's asking the question of who is global health actually for? Who do we protect in global health? And what interests are we protecting in particular? And again, I don't really have a concrete answer to that question, but I can almost deduce from all of these kind of various tensions and contradictions that I don't think it's people that we're really focused on, which, and global health is very vast. It's not just understanding the international politics of global health governance, for example, but it's also health equity research, it's social determinants of health, it's understanding the geographies of care and responsibilities, for example. But most of the time we kind of come into conflict with power. And I think that also goes back to the totality question as well, is how do we conceive power? How do we understand how power is operationalized? And is it possible for us to kind of change that structures of power to then meet the needs of people when it comes to addressing global public health issues? Because at the moment it doesn't feel like that's possible. But I think it's, again, the problem of totality, where we're just too focused on seeing everything in whole, that we don't understand how these structural forces are operationalized. So I think it's perhaps the first place to start, if it hasn't been started already, which I can imagine a lot of people are doing this legwork at the moment. But I think it's starting with, trying to dispel those kind of myths around we can't change these systems because they're so set in place, they're so set in stone that it's impossible. When really it's not possible, we just don't really know what maintains these structures in the first place.
Ada, thank you so much. Is there anything else you want to say before we finish?
No, I think, thank you so much for inviting me to the podcast. It was really great. And again, it's really nice to kind of engage with people who are taking more of a social science approach to some of these major issues and trying to challenge that by that kind of biomedical paradigm. So thank you so much for having me.
Well, thank you so much, and thank you to everyone listening today. We'll be back with another episode of Thinking in Between very soon.